Yes.
Sandeep, welcome.
Hey, how are you?
Sandeep, nice to see you.
Same, Victor, seeing you after a long time.
And it's
Sait
nice.
Naderi.
Hi.
Hello, Sait.
Hi, Sait.
Hi,
Hello.
Prabhupada. Hi. How are you doing?
Very fine.
Okay.
Thanks. Mexico is doing, in these days, COVID disease is diminished little by little, but it's improving.
Okay.
Paolo,
Yeah.
good afternoon. Good to have you here. Welcome. You just need to unmute yourself.
Pablo, nice to see you.
Where is Paulo? Oh. Hi, Paulo.
Hi, how are you?
Fine.
Good to see all of you. Hi, Victor.
Hello.
So we have 4 minutes to go. Yousuf is our senior registrar. So he will be going through the anatomy bit. Anyway, we have 4 minutes to go. And we are waiting for Mehmet to join and Ioannis, who's our other co-moderator.
Also,
Is Ioannis here?
So let's see. Imad, can you check with Ioannis where he is at the moment? And also Mehmet. I don't see him here yet.
Sandeep, Sandeep, how are you doing?
I'm doing much better now. So
Okay. How is India?
India, it's gradually getting better, but still things are not too great.
Okay. You will talk about upper and lower posterior cervical spine anatomy, right? Or only
I'll talk about posterior cervical spine, subaxial.
subaxial?
Yeah.
Okay.
Seth, we had the first session that we had was on CV junction. So it covered anterior, posterior, both of CV junction. So this is our second one, which was on subaxial cervical spine. The third one will be on thoracolumbar spine. The fourth will be sacrum and pelvis. So we divided them into 4 parts. The 2 parts are before summer and the 2 parts are after summer. So it's in July and August.
Okay.
Welcome, Mehmet.
Hi, Mehmet.
Good to see you.
Hello, Mehmet.
Hi.
Nice to see you.
Nice to see you all. Victor,
Hello.
how are you?
How are you? Fine.
Sandeep?
Thanks to God, everything is okay here in Mexico.
Yeah, good.
Much better.
Sandeep, are you good enough? You
Yes.
recovered COVID?
Yeah,
much better than 4 months ago. Much better now. Is improving.
Good, Victor. I was asking Sandeep if he recovered.
Yeah, I'm mostly recovered, but I'm having a lot of postural hypertension. So if I'm lying down, I'm perfectly all right. But if I start standing for surgery, then it gives me a lot of vertigo. But that is also getting better.
Good. How is the numbers in India? It is decreasing?
The numbers are decreasing, but because of the previous numbers that we had just a week ago, a lot of sick patients are still there. ICUs are still full. We are still losing a lot more patients. But I think in next week, 10 days, things should be better.
Yeah, good.
I think we are okay to go. So I will. I don't see Nikolay here, but I'm sure we have our moderator. So, Sait, it's all yours.
Yes. Good afternoon. It's my pleasure to be moderator of this course. Our first speaker is Dr. Mehmet Zileli from Turkey.
Sorry, Sait. The first speaker is going to be Yousuf Shaikh, who's my SR. He will be talking about neuroanatomy. So he will cover neuroanatomy first, and then we will have the clinical talks from Mehmet and Sandeep and Victor.
Okay.
Sorry, I apologize.
Okay, you can invite him.
So Yousuf has done some neuroanatomy courses with us before and has given lectures before. He's one of our actually star performer. He was a best graduate of our institution as well. So Yousuf, it's all yours. So he's going to be talking about neuroanatomy of subaxial cervical spine.
Thank you. I'll be sharing my screen now. So is it visible to everybody?
Yes.
Okay, so today we'll be talking about the anatomy of the cervical spine and some basic anatomical aspects as well as the clinical anatomy when planning anterior or posterior approaches. We know that the cervical spine is divided into two different anatomical and functional zones. Since we have covered the upper C1 and C2, which contribute to occipitocervical junction, we'll be primarily focusing on the subaxial cervical spine. Morphologically, the subaxial cervical spine is more or less the same. There is not significant variation anatomically between the different components of the subaxial cervical spine. They have a central body and they have a central canal, including a posterior arch containing the spinous process and the lamina. We'll be covering each aspect one by one. So if you look at the axial section, we can appreciate that it has a body, a lateral mass having a superior and inferior facet, a lamina and spinous process. The transverse foramen is flattened and has a foramen for transmitting the vertebral artery. In the case of C7, it also has a transverse foramen, but in only 5% of cases, it will transmit a vertebral artery. In 95% of cases, the vertebral artery does not pass through the transverse foramen of C7. And this is the central canal, and we can appreciate that the superior articular facet of fourth vertebra, which is somewhat circular in shape, and as we go down, they tend to become elongated like this. If you look at it from the coronal section, we can appreciate that the superior and inferior surface of the vertebral bodies are lined by intervertebral discs. And they also articulate with one another posterolaterally with the help of facet joints. Now, these are the facet joints, which are two synovial joints. What we can appreciate over here is that on the lateral aspect of the vertebral bodies, there is a small uncinate process that contributes to uncovertebral joint. This uncovertebral joint is not a true joint, and therefore it does not have any synovium. However, it is clinically important as this joint hypertrophy can occasionally lead to impingement on the cervical nerve roots. If we talk about the pedicles, so we know that by definition, pedicles are that part of the vertebra that connect the body with the posterior arch. So in a cervical vertebra, this represents the pedicle. So anatomically, if we ask that, is it possible to put in pedicle screws in cervical spine? The answer is yes, it is possible. But as you can see, the trajectory for a transpedicular screw in cervical spine would be quite medial. Although the length would be good because of the medial trajectory, you would have good purchase, but the margin of error is very low because medially you have a wall. Because if the breach of the medial wall would lead to involvement of the spinal cord, and breach of the lateral wall would lead to entrance into the foramen transverse area. So as mentioned here, the inner diameter of a cervical spine vertebra can be about 2.7 to 3 millimeter. So this diameter is already very small. So trying to use this for the purpose of screw placement is still possible. It is, but it is quite challenging and it is routinely not recommended. If other forms of instrumentation are not possible, only then this should be used, especially if you have supportive instruments like neuronavigation. If we talk about the superior and inferior articulating surfaces, we can appreciate that this is the lateral mass and they have a superior and inferior facet joint. On the superior aspects or the upper cervical spine, the facets are somewhat horizontal. But if you continue to go down, they become more or less oblique. And this oblique orientation allows flexion and extension movements. And they basically contribute the posterior lateral aspect or the pillars of the cervical vertebrae. How? Because they are located posteriorly and they also represent the major site where screw purchase would take place and posterior instrumentation is going to happen. We'll be coming into this when we are discussing the clinical anatomy. If we talk about the posterior structures, we know that there is a spinous process and then there is the lamina. Now, occasionally when we are doing a posterior approach, then we would identify the spinous process, work our way with subperiosteal dissection onto the lamina and then expose the lateral mass over here. But it is important that you know that the spinous process can be bifid. It tends to be bifid at C3 and C5, up to C5. So on certain occasions, one may actually enter the space. Instead of a subperiosteal dissection, you may enter the space between the spinous process and continue to go down, entering the spinal cord. So this can happen as well. The importance of lamina is that occasionally in cervical spine, translaminar screws can be done. Although not routinely used, they are more common in C2 and the lower cervical spine. Now, one of the reasons is that if you put in translaminar screws, they have a criss-cross direction. So the criss-cross direction gives better strength. The longer screw placement is possible, so you will have better purchase. But the major drawback is that the lamina can be sometimes very thin. So as depicted here, the thickness of the lamina is only 2 millimeter at C5. So a translaminar screw at C5 is just not possible. And one of the other difficulties is that if you put in a laminar screw, they will be crisscross. So connecting a rod to upper and lower levels with lateral mass screw is going to be very difficult because you'll have to significantly contour the rod. However, laminar screws are generally considered as a bailout procedure in case of fractures where lateral mass or other forms of instrumentation are not possible and the lamina is thick enough, you can consider laminar screws. Then if we talk about the discal ligamentous structures, we know that between the vertebral bodies, we have an intervertebral disc. The height of the disc tends to vary. In the upper cervical spine, just at the level of C3, it is about 16 millimeter, rising up to 20 millimeter at the level of C6, 7. We know that it has a central avascular structure that is nucleus. It has a high water content that tends to progressively decrease with age as the degeneration process sets in. And then we have surrounding annulus, which is composed of concentric lamellated fibers, which are attached to the vertebral end plates. If we talk about the important ligaments, in the vertical direction, there are two important ligaments which are running on the vertebral body, the anterior longitudinal ligament and posterior longitudinal ligament. The anterior longitudinal ligament is broad, flat, and thin. It extends from C1 down to the level of sacrum. And the major function is to prevent hyperextension injury. When we are doing an anterior cervical approach, the anterior longitudinal ligament has to be incised to gain access to the intervertebral disc space. It is further subdivided into superficial and deep fibers and intermediate fibers. The deep fibers are spanning between two adjacent vertebrae. The intermediate fibers cross 2 to 3 levels, and the superficial fibers are relatively long, crossing 5 to 7 levels. Similarly, just posterior to it, we have the posterior longitudinal ligament. Now, posterior longitudinal ligament is relatively thin, although in terms of width it is less, but in contrast to thoracolumbar spine, it is 3 to 4 times thicker. Again, the function is to prevent hyperflexion injury, and Another important element is that in cases where there is significant thickening of the posterior longitudinal ligament, it might be the actual cause causing pressure over the spinal cord. So sometimes the posterior ligament can be significantly thickened. Sometimes the process of ossification can take place, and sometimes it may actually form OPLL. So whenever we are doing an anterior approach or a CDF, other than removing the disc, you need to remove the posterior longitudinal ligament as well. Occasionally, some of the inexperienced surgeons may confuse the whitish nature of PLL with dura, but we know that dura is white, pearly, shiny. So we need to ensure that the posterior longitudinal ligament is completely removed so that dural decompression is complete. Other important ligament is the ligamentum flavum. Now, ligamentum flavum is the ligament that spans between the two lamina, from the ventral aspect of the superior lamina to the superior edge of the inferior lamina. It is again clinically and anatomically important. Color-wise, it is slightly yellow because of the high elastin content. Hence, many people also refer to it as the yellow ligament. Clinically, it can undergo significant thickening, hypertrophy, and it can cause buckling with significant compression of the spinal cord. Therefore, it is one of the important elements that helps in deciding which approach would be suitable for the patient. If there is significant thickening and pressure from the posterior aspect, then a posterior approach or laminectomy would be required. Similarly, we have other supporting ligaments such as intertransverse ligament, supraspinous ligament, and interspinous ligament. If you look at this diagram, we know that this is a sagittal weighted T2 MRI. We can appreciate the ligamentum flavum here, which is causing the distance between the two lamina. We have a supraspinous ligament extending over the spinous process. Then we have an anterior longitudinal ligament here and posterior longitudinal ligament here. This is again a cadaveric dissection where we can see a portion of disc collapse causing ventral compression. If we talk about the contents of the central canal, we know that it houses the spinal cord, and the anatomy of the spinal cord is well known. It has a central H-shaped gray matter and surrounding white matter tracts. The dorsal column is predominantly occupied by the sensory ascending tracts, and then we have a magnitude of ascending and descending tracts. There is a ventral midline fissure, there is a posterior midline fissure, and then there is anterolateral and dorsolateral sulcus for the ventral and sensory roots respectively. Now, every cervical spinal nerve is formed by the union of a dorsal sensory root and a motor ventral root. C1 is the only one which does not have a dorsal root. Hence, C1 does not have any sensory distribution or dermatomal distribution. But if you look at this diagram in an axial view, this is a cadaveric dissection. We can appreciate that this is the spinal cord, an H-shaped gray matter, and this is the cervical spinal nerve root. We can appreciate that it appears to be transiently compressed over here. Now, what this represents is the uncus, that is the uncovertebral joint. So it is important that we understand the basic anatomy and the boundaries of the neural foramen, so that our objective of neural decompression can always be met. So medially, as I mentioned, it is covered by uncovertebral joint. So if you were to decompress this case anteriorly, simple anterior decompression, removing the anterior disc from here to here would not help. So we need to take the uncovertebral joint as well in order to achieve good decompression, and it bounds as it forms the anteromedial boundary. Similarly, laterally, we have the vertebral arteries, which are quite lateral to it. So if you continue to go lateral beyond the uncovertebral joint, only then there is a risk of vertebral artery injury. Otherwise, in a routine anterior approach, you are relatively safe. Superiorly and inferiorly, the neural foramen is bounded by the pedicles of the upper and lower vertebra, and posteriorly and posterolaterally we have the facet joint. Again, in a setting of severe cervical spine degeneration, we can have narrowing of the neural foramen because the disc height would be reduced. There will be pressure from the anterior aspect with the disc, anteromedial compression from the uncovertebral joint, and posterolateral compression from the hypertrophic facets. And we know that every cervical spinal nerve root passes above their corresponding vertebra, except C8, which passes below the C7 vertebra. If you talk about the vasculature of the cervical spine, it has a very sophisticated anatomy and arterial distribution along with venous distribution. The arterial system is predominantly supplied by the vertebral arteries, and the vertebral arteries in turn give rise to the anterior spinal artery and two posterior spinal arteries. It is important to remember that the posterior spinal arteries are two in number and they are paired. Then we have a centripetal system and centrifugal system. Now the centripetal system is the thin vessels or thin capillaries which are distributed circumferentially around the spinal cord, whereas the centrifugal system are the vessels that penetrate deep into the gray matter and supply it. Now, clinically, anterior spinal artery is more important than posterior spinal artery because it is responsible for supplying the anterior two-thirds of the spinal cord. Because the anterior two-thirds of the spinal cord houses predominantly the motor tracts, therefore, in a setting where anterior spinal artery is injured or it is infarcted, there will be the resultant effects would be either quadriplegia or hemiplegia. Whereas on the other hand, if the posterior spinal artery is infarcted, then in those circumstances you will have defects of the dorsal column, sensory disturbance, but the motor component or the motor power would be more or less intact. Therefore, injury to anterior spinal artery carries the worst outcome. Vertebral artery is an important vessel that passes through the transverse foramina of the cervical spine. As I mentioned previously, it is divided into 4 different segments. The V1 is the portion from where it originates up till it enters the transverse foramen. In 87% of cases, it will enter the transverse foramen of C6, but in only 5% of cases, it will pass through the transverse foramen of C7. The second part of vertebral artery is when it continues to ascend upward up to the level of C2. It is more or less a straight vertical course. Then we have a V3 where the vertebral artery tends to take a turn. It goes proximally and just above the C1, it takes a posterior course and passes over a groove on the surface C1. This represents the V3 segment. And finally, the V4 is the intracranial intradural segment where it will unite with the contralateral vertebral artery to form the basilar artery. Vertebral artery is clinically important because it can be injured if you go too far lateral in an anterior cervical approach. Like an arterial distribution, the venous system also has a very sophisticated network. We have superficial veins and deep veins. The deep veins are relatively small, which are arranged radially, which anastomose extensively with the superficial veins, which are the anterior and posterior medial veins. And similarly, this venous network also communicates extensively with the epidural venous system. The epidural venous system is clinically very important because of the presence of bidirectional flow and absence of any walls. It allows various infections to travel up and down. So this is one of the reasons that an infection in the lumbar spine can spread proximally, or infection of the cervical spine can spread distally to involve the dorsal spine as well. This route might also be taken by certain forms of metastasis. So this was a brief overview regarding the basic anatomy of the lower cervical spine. Because morphologically, more or less, they are the same. So this was a brief. Now we are going to talk about the 2 common classifications that we use for the purpose of classifying these subaxial cervical fractures, followed by clinically relevant surgical anatomy. So one of the classification system that we use is the AO classification. Now, AO classification is a bit difficult to remember, a little more complex, but still it gives a good description of the fracture. Type A fractures are mainly compression fractures, with A0 when there is no significant deformity, A1 with a mild wedge compression, A2 there is a split, and A3 and A4 which are incomplete and complete burst. Then we have type B, which are tension band injuries, B1 when there is a posterior tension band injury involving bone only, B2 when there is involvement of bone and ligaments, and B3 when there is an anterior tension band injury. We have bilateral injuries, and then we have translation injuries, type C, and finally F, facet injuries. Facet injuries may involve a facet with no displacement, minimal displacement, a floating lateral mass, or it can cause complete subluxation with either perched facets or completely locked facets that need reduction. The other much more common classification that we routinely use is the CLIX. It is very much similar to the thoracolumbar injury classification score, incorporating only 3 elements. That is the morphology, the integrity of the discoligamentous complex, and neurological status. So in terms of morphology, a compression carries 1 point, burst 2, distraction 3, and translation 4. The discoligamentous complex, if injured, carries 2 points, and if you are unsure or if there is intermediate, then it is 1. Similarly, neurological status, intact 0, complete 2, and incomplete 3. So if your total score is more than 4, then this indicates surgical intervention. 4, it indicates that yes, it may depend upon surgeon's preference, and less than 4 indicates conservative management. So when we talk about the surgical aspects of the anatomy and the approaching the lesion, so we know that when we are doing an anterior approach, in most of the cases we would confirm the level multiple times, and it is usually recommended to do that before you do a discectomy with the help of fluoroscope. But despite that, it is important that we are aware of the surface landmarks. We know that C2 corresponds to the angle of mandible, the hyoid bone corresponds to C4, thyroid at C5, and cricoid cartilage at C6. So this is the surface anatomy that we should be aware of. Okay, so I put in a question to ask on the surface marking C2 corresponds to what level. So it's the angle of mandible. It was supposed to come after the click, but I'm sure everybody knows it now. So now that we are talking about an anterior approach, there are 2 ways to do it. One is the standard anterior approach that we do for an anterior cervical discectomy, that is between the tracheoesophagus and between the common carotid vessels, which will directly expose the vertebral body and the disc space. The other is a lateral approach, which is between the carotid vessels and sternocleidomastoid. Now, the lateral approach is largely restricted for various neurofibromas or other lesions which are going laterally, involving the neural foramen or abutting or encircling the vertebral artery. But for a routine anterior discectomy, this is the most common approach. So what are the anatomical structures over here? We know that we will utilize the normal plane. If we give an incision after level conformation at the level of skin, then we will come across platysma. After incising the platysma, we will develop a plane over here. Now, this is a natural cleavage plane. You will usually not encounter any major structures over here. But the common carotid artery serves as an important anatomical landmark. You will usually put your finger onto the artery, you will feel the pulsation, and then you will draw your finger medially and anteriorly until you feel the vertebral body. And this is usually blunt dissection, and usually you will not identify any veins over here. The relevant muscles that will come over here, you need to be aware of the sternocleidomastoid, which demarcates the lateral most limit. You don't need to go over here. And then we have longus capitis muscle, longus coli muscle, which is clinically very important because you need to dissect longus coli 3 to 2 millimeter in order to put in your retractors, the trimline retractors. But going too deep under the longus coli muscle, which would injure the sympathetic chain. And then we have the scalene muscle. I will be describing these muscles step by step in a 3D animation. So this is the diagram. We can see that under the skin lies these thin facial layers, which is the platysma muscle. Then under the platysma, we have these muscles coursing medially. This is sternocleidomastoid. These are, then if we remove the sternocleidomastoid, we have these cutaneous anterior muscles. And finally, we have these longus colli muscles. These are the longus colli muscles that have to be removed to gain adequate access to the disc space. The other important structures which are in close proximity are the vessels, nerves, and viscera. So talking one by one, the vessels in these vicinity are the common carotid artery and the jugular venous system. As I mentioned previously, the common carotid artery is an anatomical landmark because you will usually feel it with the help of your finger. And once you have identified the carotid, you will then proceed medially to identify the vertebral body. Then we have the venous system of jugular vein. You will usually encounter one or two veins, but if you take a vein by mistake, it will not lead to any deficit. If there is a vein that continues to ooze, you can also ligate it, but there is no need to specifically go after a vein to ligate it. If there is no bleeding, then ideally the veins should be left intact. The vertebral arteries which are present in the transverse foramen can only be injured once you are doing anterior cervical discectomy and you go far too lateral, not in superficial aspects. The other important structures are the nerves. We have the glossopharyngeal, hypoglossal, vagus, but as you can appreciate, the vagus nerves, these are lateral to common carotid artery. Because our approach is directed largely medial to the common carotid artery, you would generally spare them. But the nerves which are at risk are the recurrent laryngeal nerve, predominantly in the lower cervical levels at the level of 5 and 6 or 6, 7 ACDF. The right recurrent laryngeal nerve hooking around the subclavian artery is particularly at risk of injury. Again, I will show this in a 3D diagram. Then we have again the sympathetics. As I mentioned, the sympathetic chain runs directly under the longus colli muscle. So once you go under the longus colli muscle, it should not be more than 3 millimeter, but more than 3 millimeter, you will damage the cervical sympathetics or the ganglion. There are 3 ganglions, superior at the level of 1, 2, middle at C5, 6, and the third lowermost is C7. So again, this is a diagram where we can appreciate that this in the middle, in front of C5 is the middle cervical ganglion. Then over here, in front of C7, we have the inferior cervical ganglion. Removing the muscles, if we look at this nerve, which is hooking around and curving, it is the right recurrent laryngeal nerve, because we just talked about it. It hooks around the subclavian artery and then goes upward. So if you are addressing a C7D1 or C6-7 ACDF, this recurrent laryngeal nerve would be at risk of injury. Again, this is the sympathetic trunk that we can see. This will course under the longus colli muscle. Injury to it would cause Horner syndrome. And superiorly, we have the superior most cervical ganglion. So if we were to ask what is the maximum safe distance you can go beneath the longus colli muscle, it should be 3 millimeters, just enough to allow placement of tremline retractors, good decompression of disc, but not damage the sympathetic chain. So in an anterior approach, your skin incision can either be transverse or vertical. Generally, with the transverse incision, you can address 2 levels easily. But a vertical approach may be given if you are addressing 3 levels. Sometimes you can give 2 transverse incisions as well because they tend to heal very well, leaving minimal scar. Once you have confirmed the level, given a skin incision, divided the platysma, this is how you go about it, and what I have been telling previously. With the help of your finger, feel the carotid and then direct it anteriorly and medially. Eventually, you will feel the anterior hard vertebral bodies, and this is where you need to perform surgery at the level of disc space. Occasionally, patients with degenerated cervical disease will have significant large osteophytes. So you will be able to appreciate those osteophytes as well. Again, we have an anterior approach. The retractors are in under the longus colli muscle. We can appreciate the disc spaces, the vertebral bodies. Now, these are the retractors put in to distract the vertebral bodies. One may choose to use them or not, but it is not routinely recommended. But if you want to achieve, if you want the ease of working, then distraction is a better option. Now comes the important part of neural decompression. Now I have seen people do anterior cervical discectomy without microscope, but the point is that you will not be able to do complete decompression without it, because the first element is to first of all remove the anterior osteophytes that will keep coming in our way and will prevent the passage of instruments. Once you have done that, you will then remove the disc and then the end plates. Scraping of the end plates is very important because whatever graft you put in cage will not fuse until and unless you have exposed the cortical bone. Once you have done that, the final part which is often overlooked is the removal of the posterior osteophyte. Now, these osteophytes are on the posterior aspect, so you need to angle your drill, and with the help of thin footplate kerosene punch, you need to take this part. Just shown in this diagram, that when you have a drill, you will drill the disc until a very thin cortical shell has been left. Usually, this will be either a calcified posterior longitudinal ligament, or once you have incised it, it will be very thin part. You need to remove it with the help of a thin footplate kerosene punch. I cannot stress this enough because a thick footplate would cause pressure over the spinal cord. Ensure that whenever you are doing this procedure, the ablation has adequate blood pressure and MAP is above 80-85 to prevent any atogenic injury to the cord. Now, anatomically, what they recommend is that if you are doing an anterior approach and you are doing a corpectomy, the recommended minimum width is about 17 to 18 millimeters. Now, this is the recommended width so that adequate dural decompression can be achieved. But if you are doing a single level disc, then you don't need to measure how far wide you have gone, because the anatomical boundaries are there. You need to take the uncovertible joint, and with the help of a hook, you can often palpate the pedicles above and below, and then feel that the neural foramen is open. Once the neural foramen is open, you have taken the uncovertible joint, the nerve root is free, nothing more needs to be done. Then regarding the plating process, it is a relatively easy process. Try to put in a plate in the midline because the vertebral bodies are maximally thick in the region of midline. The other important aspect is that I've seen many people put in straight screws. These are okay, there is nothing wrong with it. But if you slightly angle the screws medially and superiorly, then because of the angulation, the pull-out strength is reduced. So the possibility of the plate coming anterior and pulling out is reduced if you slightly angle the screws. Now, this is again a typical anterior approach. In this approach, you can appreciate that there's only a unilateral disc collapse. So a routine anterior approach, but instead of going or addressing the entire disc space, only a level of the disc is addressed. The protruded disc portion is removed. The uncovertible joint or this part is removed, and then we can appreciate the cervical spinal nerve, which is completely decompressed. If we talk about the posterior aspects, then posterior surgery largely includes the lateral mass screws that we tend to place frequently. Now we have a lot of senior surgeons over here, and most of them would generally say that these are the easiest screws to put in because they would not even use fluoroscope. So, and what is the ideal entry point? Well, after adequate incision and exposure, you need to fully expose the lateral mass. Then you identify the exact midline of lateral mass, that is the center, and your entry point is 2 millimeter medial and 2 millimeter inferior to it. Some say just 2 millimeter medial, and some say just maybe 2 millimeter inferior, but medial is okay. So now, if you talk about the screw trajectory, then there are two options regarding it. there is either a straight technique, which was the Roy Camel technique, and then we have the angulated technique, which is the Megrel technique. The straight technique was the Royal Camel technique, which was slightly associated with higher risk of injuries. So what basically used to happen was that if you put in a straight screw, so a straight screw has to fall short of the transverse foramen. If you go too deep, you will injure the vertebral artery. So this was one of the risks associated with Roy Camel technique. The other problem was that if you put in a straight screw, you are going through a shorter distance. So a shorter distance would mean less purchase and less strength of the construct. The other limitation was that with the straight screw, you will often end up violating the facet joint of the inferior aspect. So these were the limitations. However, Megrel technique is somewhat better. It says that we should angulate the screws 25 degree lateral and 25 degree superior, or just parallel to the facets. Now, the important aspect is that once you direct the screws laterally, so your screws would be going lateral, the risk of injury to the vertebral artery would be reduced. Secondly, because you are going through the long axis of the facet, so the screw length would be more, the purchase would be better, and the possibility of getting a good construct would be higher. So this would be a good construct and good purchase screw. So these are the differences between Roy Camel and Megrel technique. Quantitatively, if we compare the two techniques, the risk of vertebral artery injury or nerve root injury is relatively low in both. But descriptive wise, these were the differences between the two techniques. Now this is the diagram. If we talk about this screw, that is a lateral mass screw, we can see that it is not starting at the ideal point. The ideal point, as we mentioned, should be the center and then 2 millimeter medial to it. And then you can direct a screw that is 25 degree lateral and 25 degree superior. So this would have been an ideal trajectory for a lateral mass screw. And because of the lateral orientation, we will spare the vertebral artery, just like this. And intraoperatively, we need to be wary of the following aspects. If you are using the fluoroscope, then you will need to know these important landmarks. This is the lateral mass, this is the facet joint, this is the lamina, and this is the small pedicles with spinal process. So your screws would be going like this. So I think this was all regarding the anatomy. Because subaxial cervical spine is not much complex, unlike the CV junction, so it was covered quick. And then we briefly talked about the clinically relevant structures adjacent to the cervical spine that you would encounter in an anterior and posterior approach. In the end, I would acknowledge Dr. Gibran, our spinal fellow, who had helped me with these amazing pictures, and Dr. Salman for providing all the 3D animations that we had. Thank you.
Thank you very much, Mr. Yousuf Shaikh, for his outstanding talk. I think there is no question in the chat section. Maybe our moderator or Salman Sharif, do you have any question or contribution?
Ioannis, who's the other moderator, please, if you could unmute yourself. Ioannis, please unmute yourself. Yes.
I have done it. Okay.
We can start with our clinical talks and then we can have discussion at the end. That might be a better idea because we have learned anatomy. So Ioannis, you want to introduce, or maybe Sait, you can introduce the first speaker, please.
Okay, I would like to introduce Dr. Mehmet Zileli from Turkey, from Ege University. He's senior neurosurgeon and spine surgeon. Dr. Zileli will talk about anterior subaxial cervical spine surgery and anatomy. Dr. Zileli.
Hi, everybody. It's nice to meet you here. Actually, the anatomy lecture was very nice, really, but it also included our talks. Probably we can shorten it a bit. I'm sharing my screen. Yes. Is it okay? You see my screen?
Yes.
Yes.
Thank you. Cervical anterior approach is a very well-known approach. Actually, I will stress a few points on this anatomy. Actually, in the mid-cervical spine, the longus colli muscles, the width between longus colli muscles are quite larger, but in the upper cervical spine, it is not that much. They get close together. And I must stress that just under the longus colli muscles, you can find the foramen transversarium and the vertebral artery. So this is the longus colli. If you go very deep to the longus colli, you can introduce to the artery. The uncinate processes are U-shaped like this. In a case of anterior foraminectomy, you mostly drill the uncinate process and work around here. Here you can see in this cross section, this is the longus colli, and just underneath the vertebral artery. And the nerve root is below that. But the artery is quite far from the midline. You cannot easily find the artery if there is no variations. Here you can see in this section, the artery, the uncinate process. Normally in the median corpectomy, you remove this part, but in anterior foraminectomy, you remove this part. So just under the vertebral artery, you will see the nerve root with spinal ganglia, and this is the more medial part of the root. Yes, another view. There are two options, transverse incision or longitudinal incision for our approaches. Transverse incision is good for 1-2 levels approaches. If you prefer multi-level approaches, you then must do a oblique longitudinal incision parallel to the sternocleidomastoid. Some surgeons, especially from United States, have done left-sided incision and surgery. But the reason was that because of the anatomical variation, they were thinking that the recurrent laryngeal nerve palsy would be much less with a left-sided approach. However, now we know that there are very nice comparative studies. There is no difference about that. And the main concern must be the endotracheal cuff pressure. So if the reason of the recurrent laryngeal nerve palsy is not from the dissection, but it's because of continuous compression of the nerve between trachea and your medial retractor, automatic retractor. So if your surgery is very long surgery, it's better that you release your retractor for a while and ask the anesthetist to deflate the balloon of endotracheal tube. you can use manual, automatic, or table-mounted retractors. There are many options about that. And the better is that the teeth of the manual retractor or automatic retractor should be under longus colli muscle. If it is not, then you have the possibility to injure the esophagus. You must be careful about this. Our friend Yousuf has described the medial to carotid sheath approach. It's the most common approach we use. Lateral to the carotid sheath can be used if there is a schwannoma in the foramen, or if you want to do a oblique corpectomy, it's possible. But if even in this instance, you retract the sternocleidomastoid muscle to lateral. If you do it, if you retract the sternocleidomastoid muscle and artery and vein, carotid and jugular vein, medially together, then this is a lateral approach. Sometimes you have to ligate the superior or inferior thyroidal arteries and veins to open your space too much, and you can cut this muscle, but it's not very necessary, especially in 1-2 level anterior approaches. There are many options, as you know. This is ACD, anterior cervical discectomy without fusion, ACDF with fusion, ACCF, anterior cervical corpectomy and fusion. These abbreviations are very much used in the literature, and we must be familiar with them. There are also anterior foraminotomy and oblique corpectomy. I find myself very sympathetic to those approaches, and these are less invasive techniques. I will tell you something about them. The anterior surgery main advantage is the compression is usually anterior. Fusion of the disc space provides desired immobility of the level. However, because of the fusion, adjacent level disease may happen, and the complications of anterior surgery can be somewhat higher than posterior surgery, using pituitary forceps, curettes, or drills. All are possible. But you must be very careful. If you look from the right side, it is very common that the surgeon neglect its own side, ipsilateral side. I mean, if you are looking from the right side, it's very common that you neglect right side decompression. You do mostly the left decompressions. So you must force yourself to make a there is even some surgeons who suggest to use both sides approaches for a good decompression. I mean, one incision on the right, the other incision on the left, and then you look from the left side as well. Anterior microforaminotomy is an approach that you can use for laterally situated, located disc herniation. Then you drill the uncus of the vertebra. And this is one case of mine, C5, C6, lateral disc herniation, a soft disc herniation. You see in the T2 weighted image, it is still much water content. Yes, this is a very small video. This is the disc space. This is the anterior longitudinal ligament, lateral part, and I'm retracting the longus colli muscle. And after some drilling, I come to the posterior part of the uncus. Now with a probe, I look underneath the ligament. This is the ligament. Now this is the disc herniation. There is some bleeding. Yes. Yes. Just underneath, you can see the dura because I removed a part of the ligament. And with this approach, I don't touch this space too much. So then you don't need to place any cage, any graft, anything. Yes, it is finished. Some coagulation with bipolar and finished. It is 7 to 8 millimeter long drilling. Yes, this is it. And another alternative for this is a more wider approach by using an oblique corpectomy, remove posterior part of the vertebral body in cervical spondylotic myelopathy cases. This is first described by Bernard George from France. What is the advantage? No fusion is necessary, no significant instability. However, it may be technically demanding because you are very close to the vertebral artery, and the Horner syndrome may be a complication of that. Why? Because you retract the longus colli muscle. Although Bernard George was at the beginning retracting like this, I'm currently retracting from the medial. So then if you don't touch the fascia of the longus colli, it's very uncommon to have a Horner syndrome because the sympathetic chain is just underneath the longus colli fascia. Indications are same with corpectomy. If soft disc herniation or posterior compressive lesions or instability, if there is significant kyphosis, you must not do it. Main advantages, fusion and instrumentation are not necessary. Yes, these are some steps. We can skip those slides. And I can show you a few cases. This is a multi-level anterior compression. I have done oblique corpectomy. This is postoperative CT scans. And this is post-op films. You can see the side of the approach. Actually, we recommend that you come from the more symptomatic side. If it is right side, you come from right, but if it is left side, you come from left. This is pre-op and post-op films. Although there is mild kyphosis, I have done an oblique corpectomy and no kyphosis developed afterwards. This is 3-level anterior compression. Yes, and straightened spine. We've done a 3-level anterior decompression with oblique corpectomy. These are the postoperative CT scans and good result. However, what we make mostly, it is a median corpectomy. As our friend described, it has to be 15 to 18 millimeter width, and you must try to stay in the midline. In the past, we were placing the grafts with opening some grooves on the upper and lower vertebral bodies. it was like this, opening a groove here and then placing the graft inside those grooves. It was quite difficult, and we were keeping the patient in rigid collars for long periods after surgery. Even with that, there was many cases with graft dislocations. Today, we always use, after a corpectomy, we always use a plate. With current standards, if it is 1 or 2 level corpectomy, anterior plate must be added. If it's a 3 level corpectomy, posterior fixation should be done. If, however, skip corpectomy, it prevents posterior fixation. Oblique corpectomy prevents any fixation. These are some examples of 3 levels corpectomy which has failed. Another from the slides from Dr. Ed Benzel. This has dislocated, but not anteriorly, posteriorly. This is more complicated because it will then compress the spinal cord itself. You can apply some maneuvers in anterior approaches. Like this, if it is a skip corpectomy, you do a corpectomy here, another corpectomy here. Then with a lordotic plate, you can push the midline vertebral body ventrally, so then you can provide some lordosis with this technique. Yes, there are many complications. They are about 20 to 25%. Most common complication is dysphagia, swallowing difficulty. Then hoarseness, but it is not too common if you take care about the endotracheal tube cuff. Graft-related complications may be quite common. It is avoided with oblique corpectomy. Nowadays, if there is no significant kyphosis, I spare all the cases from doing a corpectomy, and I do an oblique corpectomy or less invasive approaches. This case had an old case, had an anterior 2-level discectomy, ACDF, but you can see after surgery, we noticed that one of the grafts has been dislocated backwards, which is pushing the spine canal and spinal cord. We have to revise it. I will finish my talk here because lateral approach is somewhat very uncommon and very few indications there are. Thank you for listening to me.
Thank you very much. Actually, there are 3 questions in the chat, but probably we discuss it at the end of all talks, right?
Yeah, okay, good.
Maybe Dr. Ioannis want to invite the second speaker.
The second speaker is Dr. Sandeep Paisya from India, and he's a very good spinal surgeon, and I invite him to talk. Thank you.
Oh, can you see my screen?
Not yet.
Not yet. You need to unmute yourself, Sandeep.
Ioannis, if there is a delay, if Sandeep doesn't have his slides, maybe we can have Victor to follow, and Sandeep can do it in the end.
Okay. If Victor Hugo is a very good surgeon and also from Mexico, if he's ready, he can share his knowledge about anatomy with us. Thank you.
Can you see the whole screen? Yes?
Yes, we can.
Okay, thank you. Okay, I'm very honored to be here in this course with all of you. I'm going to talk a little bit about spine models. They have been made in with some molds of silicon, and we can get these beautiful spine, cervical spine models to get some skills about the bone anatomy and also the vertebral arteries and its trajectory. So we can make these models in resin, one per one, and in the right side in a transparent color. And this is a degenerative spine, cervical spine model. You can see the degenerative change in this model. And we can do some exercise with the direction and the entry. And in the left side, we have the model. In the right side, we have an anterior view of dissection of cervical spine. I am displacing the vertebral artery in this picture. So here we have an example. If we make the hole in the facet, we should be careful not to go more than 10 or 12 millimeters, because we can damage the vertebral artery and also the nerve. This is another video, and this is a very special in C1 and C2. We can see the trajectory of the screw fixation with these models. And then, for example, in the superior part, we have the anterior aspect of the cervical spine. And in this video, I'm showing you an injection in a very small cervical artery. This is the posterior view, the facets. And if we do some exercise in cadaver, we can get these images, and we can see all the anatomical aspects in these cases. And then to demonstrate the correct screw into the facet. And this is another video to see an injection of these very small arteries in the anterior aspect of the cervical spine. This is a beautiful picture about the posterior aspect of the dissection of the cervical spine. We can see the spinal ganglion and this the nerves. This is another view of some exercise in the cadaver workshop. And this is another video about an injection of these small arteries. As you know, we should take care of the vertebral artery and also this small radical in order to avoid damage into the cervical spine. Another view of this dissection. Another view, C1, C2, C3 levels. And this is all. Thank you very much, Dr. Salman Sharif.
Thank you, Victor.
Thank you very much, Victor.
Thank
Ioannis,
you,
go on.
Ioannis.
Oh, should I share?
Salman.
Yes, Ioannis, please carry on.
Okay. Sandeep, I don't know, are you ready to continue with your presentation? Okay, thank you.
Yeah, can you see it?
Yes.
Okay.
Yes.
So
Yes, we can see the full screen. It's okay.
the posterior approaches to the subaxial cervical spine and into anatomy. The anatomy part has been beautifully covered by Dr. Yousuf, so I won't really dwell too much on the anatomy part, and I'll just go through these slides. So basically, when you open the exposure of the subaxial spine posteriorly is much more easier. Just make an incision in the midline, cut down the fascia to the spinous processes, do a subperiosteal dissection, and then retract the muscles laterally up to the lateral margin of the but if you are doing a minimally invasive procedure, then you go paramedian, and then you don't really have to dissect the muscle. So we'll come to that later. And these are the ligaments that you see in the cervical spine, neurovascular structures, the vertebral artery going through the foramen and the spinal nerves. And this is the posterior spinal musculature, which you will see as you go from superficial to the deep. And the splenius capitis, splenius coli, levator scapulis, semispinalis capitis, and then spinalis and semispinalis coli, longissimus capitis and interspinalis coli, and these intertransverse serine and longissimus coli. Actually, you really don't see these muscles because you just do a subperiosteal dissection and then take it on the side. So I'll basically come straight to the approaches and their anatomy. So the usual indications for posterior approaches would be trauma, degenerative, and tumors. In trauma, lateral mass fusion as a standalone technique is used sometime or many times to supplement the anterior fusion. Occasionally, it can be a hybrid construct for cervicodorsal fixation. Sometimes you have to reduce the jumped facet joints, and then you can do that posteriorly. In the tumors, there can be extradural tumors, which are usually operated by performing a laminectomy. If it's a small tumor, you can do it with a minimally invasive approach, but larger tumors would require multi-level laminectomy and sometimes fusion along with it. Intradural tumors can be operated by minimally invasive techniques or larger tumors with the laminoplasty. Laminectomy can also be done, but generally it is not preferred for swan neck deformity. Same for intramedullary tumors. A small tumor a single level tumor, a laminectomy may be done, but for larger multi-level tumors, a laminoplasty is a far more preferable approach. In degenerative, the most common indications would be cervical OPLL and spondylotic myelopathy. And in some cases of focal canal stenosis, or there can be foraminal stenosis or a foraminal disc herniation. These can be tackled with a minimally invasive approach by an endoscope or a tube. So the commonest posterior cervical procedures are a laminectomy, lateral mass fixation, laminoplasty, and minimally invasive procedures. Laminectomy has been the oldest cervical spine procedure which has been performed regularly since 1950s. There are few indications now for doing a laminectomy alone without a fixation, but it still can be performed in patients when the anterior cervical spine is already fused. So coming to lateral mass fixation, Yousuf discussed the anatomy of lateral mass fixation. Megal technique is the most commonly used technique, and you go 25 to 30 degree lateral and above. Basically, you have to be sure that you are parallel to the facet joint and your trajectory will be correct. There is a risk of neurovascular injury, but this, as he mentioned, that this is such a safe procedure that this injury should be extremely rare. I have not seen a single neuro or vascular injury in last 20 years. So this is a thing, if you go wrong, then you can injure either the vessel or the nerve. This is a typical X-ray that you will see after laminectomy and lateral mass fixation. I will show a small video where you can see that this is a Penfield dissector going into the facet joint. You can see the you can direct it parallel to the facet joint. So this square is the lateral mass. So just medial and just inferior-medial to the center of the facet joint, you make a drill. You drill the cortex. So I drill it for about 5 millimeters and at all the levels, check it with a drill. And then I use a hand drill to make it deep. So I initially use a 14 millimeter drill up to 14 millimeter depth, and then I increase it in increments of 2 millimeters. Then you just tap it and then put in the screw. If there is bleeding from any particular hole, the easiest way to stop it is by putting the screw in that first. So it will stop the bleeding immediately. So here, after drilling all the holes and checking the trajectory and the integrity of the trajectory, you put in the screws. Now we have put in 4 screws on that side, and similarly the procedure is being done on the other side. So I'll just forward it. I never use Siam for this. It is such a safe, simple trajectory. So after putting in the screw, you use a curved rod to maintain the cervical lordosis, and then you put in the screws. So this is the end construct. And if you have to do a laminectomy, then I do it after I put in the screws and fix it, so that the spine is stable at the time of doing a laminectomy. So this was the patient that I was showing the video. We operated just a few days ago. This patient had a 2-level corpectomy 3 months before, and she was complaining of neck pain, and the routine scan showed that, a routine X-ray showed that she had dislodgement of the cage at the lower end, and which had damaged the anterior cortex. So we ended up doing initially C4-5 corpectomy was done, but we ended up doing a C6 corpectomy also. But it was a 3-level corpectomy, so we supplemented it with a posterior fixation too. So this is another, I'll just show you some examples. This is another patient who was operated anteriorly before, many years before. And then he developed spastic paraparesis for 1 year before the surgery. So we did a 3-level laminectomy and lateral mass fixation. Again, the other indications for doing such procedures would be in such patients where you have to supplement the anterior fusion. So this was a patient operated elsewhere. As you can see, the patient has got kyphosis and significant OPLL at multiple levels. But only C4 corpectomy was done and decompression was done. Patient woke up with significant quadriparesis. He came to me, I think, 4 or 5 months after this surgery was done. And he was severely quadriparetic and came on a stretcher. So this was the MRI done at that time. As you can see, the kyphosis is corrected to some extent. The spine is straight now, but there is significant compression still. So instead of doing anteriorly again, then we did posteriorly, did a multi-level laminectomy and lateral mass fixation. The patient did quite well, actually. So this was another patient who had a C4-5 corpectomy, did well after surgery. Routine X-ray 3 months later revealed a cage subsidence. So we supplemented it posteriorly, but he was extremely osteoporotic, so we did a C7 pedicle screw also to extend the fusion. So the commonest approach procedure posteriorly is laminoplasty. So laminoplasty, there are many techniques of laminoplasty. It was popularized by Japanese surgeons in 1970s. And since then, many techniques have evolved and there are hundreds of papers on that. But the two commonest procedures done are open door laminoplasty and French double door laminoplasty. So I'll just be showing these. Laminoforaminectomy can be an adjunct to laminoplasty or a laminectomy, particularly if patient has root symptoms on that side. Or if there is only a foraminal stenosis at a single level, then one can easily do it with a minimally invasive approach. So this is an open door laminoplasty. We drill the cortex on one side completely till the dura. And then on the other side, you make it eggshell thin till the only thin shell of the inner cortex remains. And then you lift the whole complex of the spinous processes to tilt it to one side. As you can see here, it is tilted to one side. And then you put in a plate or a graft in between to keep it in that position. If you don't do that, then once you close the muscle, it will fall back and there will be compression again. So this is an example of a French double door laminoplasty in which you make grooves on either side of the lamina. Then you open the spinous processes in the center and you cut open all the spinous processes. And then you split the spinous processes and put in a graft in between to keep them separate. So this provides a pretty big opening. So various studies have shown that whether you do a double door laminoplasty or an open door laminoplasty, the results are similar and it gives approximately same amount of space to the spinal cord. I personally find open door laminoplasty a less tedious procedure, so we do open door laminoplasty in all the patients. So this is in a cadaver model to show what is being done. So in the first, you can see it is an open door laminoplasty. The lamina is opened up and there is a graft put in there, or you can use a plate to keep it separate. While in the second one, this is a double door laminoplasty. You split it open and you put in a graft in between. Another use of laminoplasty is in intramedullary tumors or long segment intradural extramedullary tumors. So this was a patient, 30-year-old guy with intramedullary tumor. We did an en bloc laminoplasty at 4 levels. And once you lift the lamina, I usually prefer to keep it attached on one side to the muscles so that the vascularity is maintained. And once the tumor is out, we fix it back. As you can see in the second image, the tumor is out completely, and you can see the complete integrity of the ligamentous complex and the spinous processes. They are well in place. And the cervical lordosis is well maintained. So it is very important that you don't do a laminectomy in such patients, because otherwise later on they will develop swan neck deformity. This is the most common use of cervical, either lateral mass fixation or a cervical laminoplasty, a long segment OPLL. So this was a 69-year-old patient who developed spastic quadriparesis after a fall. So we did a long level laminoplasty. This is a post-op X-ray to show just the plates in place. This was another patient who came to us. He had a cervical OPLL, and another surgeon had done a laminoplasty. But you can see that he did everything right, but except for the fact that when he put in the plate, he put the laminas back in the same position and then just fixed in situ like that. So it was as before. The compression continued and the patient continued to have quadriparesis. So later on, when he came to us, we had to revise the procedure, opened up the plate, and then increase the space. Now coming to some minimally invasive techniques. Usually you can do it by a port or an endoscope. I normally prefer to use a port to do all my decompressions. As you can see here, in this patient, in the last image, you can see the angle, the trajectory which has been taken, and the decompression has been done through that. So MIS techniques can be used for decompression in canal stenosis, foraminectomy, posterior discectomy, intradural tumors, and small arterial tumors. I personally don't have any experience of doing foraminectomy posteriorly. I just did it in one patient many years ago. And that's it. I have not done a single discectomy, but there are a lot of papers in literature, and particularly in a foraminal disc herniation, it can be done pretty well. You don't really require any implant in that, and no fixation is required anteriorly. Posterior decompression in canal stenosis is just like doing in lumbar spine. You can put in a port and remove the ligamentum flavum and decompress the lamina without damaging the integrity of the spine. I'm just showing a video of an intradural tumor after this. So again, this is a slide showing lamina and foraminectomy. This is an intradural tumor. It was a neurofibroma. This is a pre-op MRI. So we approach on one side. It's an 80 millimeter tube inserted from the right side. You dock it on the lamina, drill out the lamina, but leave the spinous process, interspinous ligament intact. The facet joint is intact. Open the dura paramedially, and then you remove the tumor in piecemeal manner. It's a very elegant technique, and it doesn't cause any instability. The patient is up and about immediately after surgery, and I always discharge these patients next day of surgery. So this is at the end of surgery. You can see that beautiful spinal cord. The dura is closed completely with 6-O-proline. And once it is closed, simply the muscles fall back in place, and you just close the subcutaneous tissue and skin. This is post-op MRI showing the trajectory that we had taken. You can see the facet joint is intact, the interspinous ligament and the spinous processes are intact. And this is a small incision. Sometimes for anteriorly placed tumor, you can go even further lateral. So for routine intradural tumors in posterior lateral space, or laterally, you can go like in a routine manner, 1 to 1.5 centimeter paramedian. But sometimes when the tumors are anteriorly placed, in that case, you can go further lateral, 6 to 7 centimeter lateral, to get that flatter angle. And so we have removed this tumor with that trajectory. Unfortunately, I don't have the post-op images right now with me, but it was removed completely. And this is another patient with a recurrent arachnoid cyst, which was again operated by that technique. And this was published in World Neurosurgery. So minimally invasive techniques can be used for such lesions beautifully. Now, a brief about cervical pedicle screws. Though they are very uncommonly used, but everybody should know how to put in a cervical pedicle screws, because they help in rescuing in certain cases. So the entry point is just below the facet joint, halfway between the medial and lateral facet line. Average angulation is 45 degrees medially, and the trajectory is roughly perpendicular to the axis of the posterior elements. And the typical screw diameter would be 3.5 to 4 millimeter, as the pedicle dimension is outer dimension is 5 to 6 millimeters. Invariably, one would use navigation, because this is a very tricky thing, and the risk of neurovascular injury is pretty high in this. So you can see on one side there is vertebral artery, and the other side there is spinal cord and the nerves. So other reasons for using posterior techniques would be the facet reduction, as Dr. Zilali mentioned. From the anteriorly, you can do that. Sometimes you can do it posteriorly also. You have to drill up the jumped facet, and then you put in intervertebral spreader, or you put in curette inside it, and you can swivel it to reduce the jumped facet. And this is doing it anteriorly. So I'll just show you certain historic techniques which were used previously, but mostly they are not used now. Various type of interspinous wirings and compression wirings and facet wirings, but mostly these are, whenever you need these now, you will put in a little mass screw. So this is an example of a hybrid construct, a cervicodorsal. For cervicodorsal fusion, you can use a tapered rod or you can use an offset to connect two different rods. So this is another reason sometimes to go posteriorly. I would just like to show this one case and have opinion of the people. This was a patient who was operated by one of my colleagues. So how will you approach this patient? You can put your answers in the chat box. Oh. Sait, can you hear me?
Yes.
Yeah, because I'm on full screen mode, so I cannot open the chat box. So can you look at the answers and moderate for me?
So there is anterior approach, anterior ACDF, there's corpectomy, there's C45, C56 ACDF. Somebody wants to see CT scan, anterior approach. Another person wants to see CT. Laminoplasty is another one, C45, 56 ACDF. So there are a mixture of everything that you can name.
Yeah, but okay, so what would you prefer, Salman?
It all depends on patient's pathology and CT scan findings.
Yeah, CT scan was not done.
But, I'm fond of anterior surgery, and, I give much better results with anterior surgery. And so that's why in majority of the cases, I would do this anteriorly.
Yes, I agree.
Yeah.
A two-level anterior discectomy and fusion is enough, I think.
Yeah, I also think so, but perhaps I may end up doing a corpectomy because it is, if you see, it is going far below C4 body also. If you do a corpectomy, in that case, you can get that oblique trajectory to remove the ossified beneath the C4 also. But anyway, so the surgeon did it posteriorly. So it did a 4-level laminoplasty, and the patient actually did not improve, so ended up doing anteriorly later on. Now, this is another patient. She's a 35-year-old doctor. Actually, she works in our hospital. She is right-handed. She had C7 radiculopathy for 2 months at that time. Now it's been more than 6 months, and she had no trauma. You can see a soft disc herniated on the right side, and there was mild weakness of the triceps. She had all sorts of medicines. She did not improve. She underwent a root block procedure, which also did not help her. And so what would you do?
So anterior foraminotomy, micro laminoforaminotomy, conservative.
Of the participants.
So these are, no, I'm reading the chat. Anterior approach, ACDF. I wouldn't give you 5 options, Sandeep. Conservative first, bed rest, not fine ACDF, anterior foraminotomy, posterior foraminotomy.
So this lady was
Go on, Sandeep.
radiologist, and she did not want any fusion.
So what did you do?
No, she was not my patient. She never came to me. I'm just showing this patient here. So she showed to various surgeons. And so again, as you said, that she was given a lot of options, both anterior, posterior, fusion, foraminotomy, all that. Ultimately, she just decided not to do anything. She was on collar for more than a year. And now actually, I still see her in collar, but she's doing quite all right without any pain. So sometimes just not doing anything may also improve things.
Yeah, that's your first option, obviously. Very good.
So, okay, with that, I'll just finish and my talk.
Yes, but excuse me, Sandeep. Yeah. The indication for surgery is usually neurologic deficit. If the indication is pain, then you have the option to wait. But if it's a deficit, you don't have the option to wait.
See, ultimately, you have to go by patient's opinion, what the patient wants. All these
Yes,
surgeons,
but if he has a deficit,
I would have, if she had come to me, I would have advised her surgery, and because she did not want any fusion, perhaps the two best options would have been either an anterior artificial disc, anterior cervical discectomy with artificial disc, or a posterior foraminotomy and discectomy from there. But as personally, I mentioned that I don't have any experience of that. I perhaps would have done a artificial disc. And every surgeon she went to advise her surgery, but because she did not agree for surgery, and so she was just one of those patients where the symptoms did not worsen and she just remained all right. And in some particular patients, the symptoms may worsen also, and they may require surgery.
Yeah, can I comment on that?
Yeah, sure.
I would rather do a posterior microforaminectomy using a tube.
Yep.
Because she's a young lady and it must be a soft disc herniation. For the comment of Ioannis, if the deficit is minor deficit, you can still use conservative measures. If it's a major deficit, yes, we must always operate.
yes, I agree with you. A minor deficit, let's say muscle power of 4 to 5, it's not an indication for surgery. But if you have a deficit and it continues after conservative treatment, I don't think there is an option to go conservative.
Yeah.
And usually patients are afraid that the surgeons are aggressive, and they usually say surgery when it's not needed.
Yeah, exactly.
And this is a problem.
Sandeep has written she has for 2 months the symptoms.
It was at the time, but I think now
quite
it's been
long.
1 year.
Yeah, after 6 weeks, actually, we know that it will not spontaneously resolve. So then we can advise surgery. Good case.
Very good.
So I think we can start discussion for the talk. In the chat section, I found some questions. Most of these are about the anterior approach. I would like to start with the question of Dr. Shahid Ahmed. He asked about what in case if we damage vertebral artery during anterior surgery?
Yeah.
Dr. Zilali, would you like to?
I have some experience that I damaged artery. Most of them were tumor cases. The tumor was encasing the artery. But in one case of a redo surgery, I injured the artery during drilling because it was impossible, because of previous fusion, it was impossible to identify the borders. So then I packed the artery with some bone wax and some spongostan, and then sent the patient after surgery to angiography. And the interventional radiologist has done a coiling of a pseudoaneurysm. But in some others, they have to clip the artery, or not clipping actually, they have to embolize the artery. In 2 cases, I could, those were tumor cases, I could repair the artery by seeing the proximal and distal part, placing transient clips, and then stitching using 6-0 Prolens suture. It's not easy, yeah, but you must be cool-blooded, and then you must behave patiently, and you can manage it nicely.
But the most common treatment choice is packing with Surgistar or Sprongostan, like that, right?
So that's to start with. That's the initial treatment, but you do need angiogram after that.
Yeah, immediately after, one same day or other day. If you wait too much, then it can bleed again, because it's very common episodic aneurysm happens. And more important is if a dissecting aneurysm happens, because you can't know that if there is some dissection during your manipulations.
Okay.
And did you experience any neurological deficit because of vertebral artery injury?
In one tumor case, yes, there was some brainstem ischemia findings. Yes, we experienced one in one case only. Okay.
Another question is about the PLL. Is it mandatory to take the PLL in all cases? Dr. Mehmet Gürbüz from Turkey asked.
Yeah. If it's a soft disc herniation, if you are operating for a soft disc herniation, it's not. But if it's a spondylotic myelopathy, you should better remove the PLL always. In spinal canal stenosis, I always remove it.
Yes.
But in soft disc herniation, I don't. Right. Good question.
Okay. One participant from probably India, Dr. Kumar, asked about the use of interbody graft or spacer in 80s and 90s cases, in cases older than 80s and 90s. Should we use interbody graft, or can we use only spacer?
Cage, you mean cage with spacer? Probably.
Yes, actually, probably this is cage, yes. He wrote spacer, but this is cage. Yeah.
In the older ages, you can even do simple discectomy without fusion. If there is disc height has been very narrow, and there is some osteophyte formations. If you believe, if it is one level only, you can do just simple decompression. But there are good studies that are placing cage only, a P cage, without any bone graft, and then they have good fusion rates. So yes, it's not very, yeah, you have similar studies, I think, Sait.
Yes.
It's not very necessary to place a graft in some cages.
You're right. I agree. Probably we have no enough time, but maybe we can ask a last question. What do you think about the floating corpectomy? Probably they are talking about the floating technique in OPLL.
Yeah. Our Chinese friends have introduced that to the literature. This is done for OPLL, multi-level OPLL cases. It's a good technique, actually. In the past, some surgeons were making corpectomy, but not touching the OPLL itself for the scare of dural leakage, because if the CSF comes from ventral, it's a big deal. You cannot manage it nicely. This is better than that, but it is technically demanding, because you have to open grooves on the bodies, on the lateral parts, two grooves, and those grooves must go backwards till the ligaments. without injuring any nerve or anything. It's possible, but it's technically demanding technique.
Thank you. Ioannis, do you have any question? Would you like to ask something to participate in discussions?
The one thing I would like to ask is, in some cases, scientific use MIS, and what about the correction of lordosis? Don't you think that it's necessary to correct the lordosis so to lessen the cases of adjacent level disease? And the same question is also for Mehmet Zileli about the oblique corpectomy. What do you think about?
Sandeep
So
can answer
you
for
are
the first part.
asking about correction of kyphosis or lordosis?
Correction to have a better lordosis.
To have better lordosis.
Restoration of lordosis. Is
Restoration of lordosis, yes.
So we are talking about minimally invasive surgery in only patients who have a single level compression or a foraminal stenosis or a soft disc herniation into the foramen. Usually these patients don't have any kyphosis.
Okay, so if a patient,
interiorly.
so one of your indications in the operation with MIS in cervical spine is that they have lordosis, or if they have a straightened spine or kyphotic, you do something else?
Then we have to go anteriorly.
Okay. Okay.
Okay, good.
And
For my part,
in oblique corpectomy, when you need to do an corpectomy and you don't do a correction of the kyphosis or the strengthening without using, it's not possible without using any instrumentation. Do you see any, let's say, failed neck surgery syndrome?
No, I don't see much. But actually, as I mentioned in my talk, if there is significant kyphosis, it's a contraindication for oblique corpectomy. Because you can expect some increase of kyphosis if there is significant kyphosis. Actually, there are very nice studies who have examined in the long term, after oblique corpectomy, 10 degrees of kyphosis may be expected. The better cases to choose for such a surgery are the discs are narrow and there are significant osteophyte formations. Those patients are better indications for that. Yes, if there is significant kyphosis, you must not do it.
Thank you very much.
Thank you.
Thank you very much. Salman, probably you can.
I think
Imad, can you show the posters for the next meeting?
The quiz.
Okay, you can show it after the quiz.
so quiz Mehmet has to do this. Is this Mehmet's questions? Mehmet, these are your questions.
Yeah, this is my question.
So you want to take them, please? Just read them for everybody.
But you haven't written the question, just answer.
No, it's the what sentence below is correct, and it's given 1, 2, 3, 4, 5.
Yeah. Yes. Okay, actually, should I say the correct answer?
Yes, please.
Correct answer must be B. Anterior cervical corpectomy at 3 levels should be supported with posterior fixation.
Okay. Next, Imad, please.
Yes. What is the most common complication of anterior cervical approach? The most common complication is swallowing difficulty. It's very common. Mostly transient, actually, not permanent.
Agree.
Yeah.
Next.
what is the most common complication of an oblique corpectomy? I also mentioned that in my talk. It is the Horner syndrome. Sympathetic chain may be injured during the surgery. Yes. This is the questions of not mine.
Yousuf, these are your questions. Can you please take them? Or Sandeep, you can take them. It's about posterior approach. Entry point.
Yeah, so majority have given the right answer that it is 2 millimeter medial to the center of the lateral mass.
Good.
Good. Again, 71% have given the right answer. It is 25 degrees superior and lateral.
Good.
But can we go back to the previous question? Surprising thing is more than 10% have said that it is 25 degrees medial.
So you need to tell them what's the problem if they go medial.
They will enter the spinal cord.
Okay, so that's good. Next, please. Imad, next, yeah. Okay.
So this is again 53% have given the right answer that 15 to 18 millimeters, 15 to 17 millimeters is the median corpectomy. Okay.
Good.
So this is our next course. Next course will be on 18 July. It will be on, like today we had on cervical spine. Next one would be on thoracolumbar spine. And then the fourth session would be on sacral and pelvis. That will be on 1st August. So speakers in the thoracolumbar would be Michael Steinmetz and Francisco Costa and Onur Yaman from Turkey.
I noticed here you have placed wrong photographs of Michael.
Yeah. Michael suddenly.
Actually, it's Francisco Costa who should have been on top. So it's the names have just put.
And Francesco was younger.
So we had our first Pearl from OR course a couple of months ago, and that was on spine tumors. And the part 2 will be on deformity on 26 and 27 June. So all of you who have not registered for it, I would request you to become a member because it is free for members and only members can participate in the course. So you can become a member and then join the course. So do we have the poster for the third course also?
No, it's not yet ready. So that's all we have at the moment.
This is going to be a fantastic course. So I would request everybody who's interested in deformity to just log in for the course.
Dr. Gupta, if you want to say something, please write in the chat so that people can read. And okay, are we going to wrap up? Or are we going to? Is there anything else?
No.
No.
Okay, so can we have the group photograph again, please? And so I'd request everybody to switch on their videos so that we can get a group photograph, please. And you can smile. So, Imad, are you taking this? Imad?
Yes, sir, I'm taking it.
Thank you.
It's done.
Done?
Yes, it's done.
So the two moderators, please. Sait and Ioannis, we have to wrap up, please.
Sait, do you want to wrap up?
Okay, I think everything is was very wonderful. We are happy to have such a meeting. I would like to thank especially to Imad and Salman because of their wonderful coordination, and we can close the session.
I would like to add something, Sait, if you don't mind. I like very much the quality of all the presentations, and I wished that when I was a resident, I had the opportunity, or a junior doctor, had the opportunity to experience such good talks and so to clarify things. And I hope everybody enjoyed the same way I enjoyed. Thank you very much all for your participation.
We will wait you all to our deformity course in June 26, 27.
Thank you, ma'am. Yeah, thank you. Let's wrap up. Okay, thank you. Bye-bye.
Bye.
Thank you.
Bye.
Bye.
Thank you. Bye-bye.
Bye, Victor. Follow.